Okay, so after the inhalers talk, which is 3% of the NHS carbon footprint identified by the Green NHS, we have the 2% anaesthetic gases we want to talk about next. So we have Alifia Chakera, who is the lead pharmacist for Theatres and Anaesthetics for NHS Lothian, but she's recently been appointed the head of programme for Medical Nitrous Oxide Mitigation for Scottish Government's Healthcare Infrastructure Division. Now, those of you who watch Seaspiracy on Netflix will have heard of Sea Shepherd, and Alifia is a sustainable medicines consultant and pharmacist for them. Her research with the University of Edinburgh into nitrous oxide mitigation has altered the way in which we supply and manage this polluting agent within healthcare. Alifia founded the Nitrous Oxide Project, which was has established her lean systems approach across UK, Ireland, Australia, New Zealand, Brazil. Her team won the 2021 Barema and Association of Anaesthetists Environmental Award, and she's been highly commended in the 2021 BMJ Environmental Award as well. So, Alifia, if you can start sharing your slides, we welcome you.
Sure. Can you see me?
Yep.
Wonderful. Wonderful. Okay, great. So thank you for that introduction. I feel thoroughly intimidated by it, but thank you very much. And thank you so much for the speakers ahead of me. That was really great. I'm so glad I turned up today. That was really wonderful. So just checking you can see my screen and you can hear me. Yes, Mina?
Yes.
Wonderful. I'm going to carry on then. So yes, so this is welcome to the Nitrous Oxide Project. It's wonderful to be here on a Saturday morning. It's wonderful to see so many people here today. And yeah, so I'll just carry on. So just to give people a bit of background on the national project, our aim is to eliminate or flatten anaesthetic nitrous oxide emissions without affecting patient care. The core emphasis of our approach has been to educate on system waste and lean methodologies. We're also very keen in that objective to promote sustainable practice. So where there is a green alternative, we do encourage it. But also within this approach, we're also assessing green technologies. So looking and exploring at catalytic cracking technologies and seeing how the value of those within our health service. There is another wing to all of this, and which sort of is part of my work with Scottish Government, is also looking at medical gas suppliers and looking at their behaviours and venting practices. I won't get too much into that today, but that's another piece of work. Okay, so just give a quick overview. I'll take you through anaesthetic gases generally. I'll go over nitrous oxide system waste, which is actually quite large in the UK at least. I will then give you some tips on conducting a local project, and obviously a little bit of troubleshooting around the challenges and some links to resources, just to give that recap. Okay, so when I turned up to NHS Lothian, this is the anaesthetic gas footprint that I first tried to establish. I tried to understand our footprint. It was really useful to see Matthew's talk on carbon footprinting. So this hadn't been done in Lothian, and the anaesthetists at least were very excited when I started, sort of carbon footprinting our gases. Now, this is really typical and very typical across the UK. 23% of the emissions are made up of, this is 2018-19, of volatiles, and the rest was made up of nitrous oxide products. Now, this is really standard. Now, if you move along, now, a lot of effort was made around desflurane reduction within anaesthesia. That's because it's got a really horrific emissions footprint, and there is a substitute. You can use sevoflurane, and you will deliver at low flow, and you will deliver an anaesthetic with a smaller carbon footprint. So that was really driven through the Association of Anaesthetists, through the Royal College of Anaesthetists, through the environmental networks. They've all been working towards that program, and sure enough, our footprint has reduced on that front as a result. What I was interested in is the nitrous oxide emission footprint. So nitrous oxide has a really high global warming potential. It's around 298. It's also really quite a nasty ozone depleting substance. I've given some sizes there. I won't spend too long on this slide. I want to move on. So I've just said to you, so it is the dominant ozone depleting substance. Now that we've got rid of CFCs, limited CFCs, it is really the dominant ozone depleting substance. Is something to be aware of. It also hangs around for a really long time, has a really long atmospheric half-life. So a baby born today with gas in there will be gone, and the effects of its arrival will still be felt, which I think is worrying. Just looking at NHS sites alone, so not looking at the private sector and not looking at ambulance emissions of nitrous oxide, just healthcare sites, we're looking at 320,000 tonnes across the across NHS sites in the UK NHS sites. So that's similar to 320,000. Actually, it's a bit more flights to New York from Edinburgh. So pretty nasty. Now, this gives a really good impression, and this is what was piqued my interest. So you can see there's a real cultural change. Now, I should have flipped this around actually. The 3 bars below represent our decrease over a 12-month period in volatile emissions. So we dropped by 450 tonnes. These are pre-pandemic years. I deliberately picked pre-pandemic years. Percentage of desflurane has dropped even further. I think we were around 20% in Lothian. Now it's dropped well below 5% of total volatile bottle salt volume of volatiles. So that's so you just see how potent desflurane is really. So yeah, but I was curious, why was the nitrous oxide footprint not changing? Because this shows deep behavior changes, especially in anaesthetics, you know. So I wanted to get under that. To do that, I had to improve data quality. I realized that the data through pharmacy, it's not like a standard drug. It's not like paracetamol. We don't look at it like, how do I explain it? With paracetamol, we know exactly what's moving through it. Nitrous oxide is given out remotely, right? So we don't see it. There's a states team, supported team. So that there was an issue with data quality. I realized we needed to use medical gas supply returns data to do it. We also needed to improve data interpretation. Not different cylinders were serving different areas, and we needed to understand who was using what. And I wanted to get under the system pathways. And this was all done through the University of Edinburgh with my research with the Uni of Edinburgh. And through this, I was asking some hard questions, and I developed a system waste hypothesis. Anyway, so I tested this out, and it proved correct. I kind of figured that there was a huge amount of system loss within Lothian. We lost about 1.8 million litres across three adult sites. Every manifold was wasting. Every pipe system was losing nitrous oxide. That was roughly just over 1,000 tonnes per year. That's also led to some savings, obviously on the drug itself, but also infrastructural savings. We haven't had to install a new, refurbish a manifold for one site. We're not introducing a pipe nitrous oxide manifold for another site, a reticulated system for my Australians. So we've a lot of savings, but also in terms of maintaining these infrastructure, you don't have to pay for authorised persons to do so. So we launched the project. This has been, at around the 2-year mark when I've done all this research. We launched the project in January this year. By spring, we had 16 sites report on their nitrous oxide waste. It was massive. 13.7 million litres were not accounted for. Totaling those sites up, we knew it was 95% of their turnover was lost. We couldn't account for it. I've written a mitigation report for the Greener NHS programme, and we have devolved nation commitment. As you know, I've been pulled into Scottish Government to lead on this work, and I think this will have huge benefits to the UK, Republic of Ireland, but also the world in terms of how we work on mitigating this gas. So what's driving those system leaks? Okay, so we know, system waste, sorry. We know system leaks are a real problem. So 1 litre a minute will generate around 516,000 litres a year. Now the system does allow for leaks. So historically, we weren't that sensitive to climate change. We weren't sensitive to what was happening. But we know more now. We're not children anymore. This is a nasty gas. So we need to really think about that. Poor security is emerging as we've been doing the research, and I've had more sites that are recorded. I've just given you one since spring, but we've had a lot more feedback. Security is a real problem. Now, obviously, you'll get the lock and key breakthrough, and there is a seasonal aspect to it. So if there's if the festival season's in, New Year's, Freshers Week, you will get increased theft of nitrous oxide or Entonox. Now, sometimes the theft will be cached. What I mean by that is that it could be internal theft, and I know people get a bit uncomfortable, but it will be hidden through normal logbooks and security, so you won't actually pick it up. So I'll take cylinders away and actually vent them out at a party and through balloons or what have you, and then return them into the return store. So this is what I mean. I think through careful assessment and management, you need to maybe, if you can't work out if there's a leak, that security will be an issue. So just to bear that in mind, stock management is an issue. If you don't have good stock rotation, you overorder, all of these things will lead to waste. System design is a problem. Over specification of outlets. You can have, the more outlets you have, the more piping you have, the more prone your system is to a leak that's undetected or loss in the system. The other thing is, people make a big deal of this. If managed correctly, your pressure, if your pressure is set too high in the system, it can be a problem, but it shouldn't be. Around 5% of the gas will go back to be the medical gas supplier, because they have to keep a certain amount of pressure in the system. The larger the cylinder, the less of the percentage that will go back, but obviously that system's under pressure. So if it's not managed correctly, you're more prone to system leaks. So there's, there's things to be thought of. Inefficient clinical utility, I put these things in order of problems. Inefficient clinical utility is still an issue, less of a problem than we first thought, but still something to bear in mind. One of the example being that, in obstetrics, when a patient's coming in for a spinal, they'll run, instead of using Antonox on a demand valve, they will use nitrous oxide with oxygen as a proxy. It's continuous flow, and tens, if not hundreds of liters will get used while they're prepping for a spinal. Better to use Antonox on a demand valve. We've historically thought that GA sections use a lot of nitrous oxide. Actually, the analysis is showing it, they use very little, and we just need to think about how we're supplying it. Okay, so I'm going to take you through how to do this project yourselves. All right, so I've encouraged using a Lean Six Sigma approach within healthcare. This is an iterative approach. It asks you to build an MDT, what have you, and I'll take you through that. It also allows you to incorporate other lean tools. I strongly recommend that you develop your own strategy on your own site and your own framework, and I'll go into all of that. Now, this is a standard DMAC framework defined, which is, you build a shared aim with your stakeholders. So you want to gather them up early on. You don't want to start this work without gathering them all up. You want to measure and determine what your key metrics will be. You want to work out how you're going to analyze that data, and obviously, and then what improvements you want to make. So this is the standard framework. Okay, moving on. So the stakeholders. Now, this is the suite of stakeholders I would recommend. Now, within this, I've mentioned the Medical Gases Committee, and I've got the QA hub. Everyone's important, but this is not a standard QI project. Anesthetic gas or nitrous oxide is used in a range of a number of places. It's really important that anyone who uses anesthetic gases or anesthetic nitrous oxide needs to sort of develop a zero net strategy. How are they going to get to zero emissions of this gas? And my recommendation is, within the UK at least, they centralize this discussion with the Medical Gases Committee and sustainability leads. The other thing I would recommend is talking to QI hub or QI directorate very early on. So everyone needs to be accountable for this gas, from midwifery to theatres teams. It's everyone's business. Okay. So assessing nitrous oxide, and I'll talk you through each of these one at a time. You want to understand how much nitrous oxide is being consumed at each manifold. That is the system or the pipe system supplying a hospital. Many sites will have 1, 2, 3, one site has 5, goodness knows why, okay? You want to understand what area is being serviced by each manifold, and you want to determine clinical usage. I'll summarize all of this for you, don't worry. Okay, so the manifold audit. Now, the way to do that is by looking at logbooks. So in theory, each manifold, every time a bank is changed, it should be recorded. Now, sometimes this doesn't happen. So you will have to conduct interviews with your portering team, okay? I've put BOC data. I should put medical supply data, needs to be looked at. You need to look at the medical supply returns data, because at the moment, under EC legislation that we are compliant on, all cylinders returned will be vented. So any cylinders that go back with the residual gas will be vented. So you should need to take that returns data as the footprint data, and you want to compare that. So you split, you look at that against those. I'll go into this in more detail, don't worry. You also want to look at manifold management at this point. You want to see that they are actually performing leak tests at the manifolds. I'll go into that too, but it's usually a soap spray, and just at one site, I know they always do their leak tests religiously, especially with big N-oxy cylinders, which are really under tons of pressure. And 3 times a year they'll find a leak, and they do their leak tests weekly. So it's really important. And you can check with stock rotation. How well are they managing their stock rotation? Very important, because like I said, all return cylinders, expired or otherwise, will be vented to the environment, which is horrific. So the manifold room. This is a beautiful manifold room, actually very well managed manifold room at the Royal Infirmary of Edinburgh. It's a really big manifold supply system. It has a 6x6 J arrangement. Now a J cylinder holds 18,000 litres of nitrous oxide, okay? Now we are going roughly at this, so this is how it works. You have an active bank, okay, that's feeding the manifold. As the pressure drops to around 12.5 to 14 bar, it will flip over to the next bank. In that time, the porters have 48 hours to change the cylinders, because this is active and you've got enough active, that should last you well and truly, okay? At least 6 to 8 weeks, really. So what you can't see in this picture is an emergency reserve. So if both of these deplete and the porters haven't got there, the emergency reserve will kick in. There's 2 cylinders on that. Now, there really shouldn't be any need for that. If you go into your emergency reserve, it indicates a leak, and at one hospital, that's what it inferred. But the changes were happening so quickly, the emergency reserve was getting activated, and the porters really challenged it. Now I'm going to move along and see if you can see these connections. This is where a leak can happen. I'm not, so I probably should provide a close-up. I haven't done that. Sorry about that. But anyway. Now, this is an example of a log sheet. Now, you'll see this is for an N-ox manifold, huge EW cylinders, feeding the Royal Infirmary of really busy obstetric theatres, 11 by 11 changes, okay? So 11 cylinders will get changed at a time. You can see the porters tick the left-hand bank, and every time they'll document that, okay? So it's very easy then from that to calculate the volume of turnover at that one particular manifold if they're doing good recording. Now, in terms of the pipe schematics, this is actually a really fun piece of work to do. And I would really encourage your clinicians, your midwives to do this. And pharmacists should really pay attention to what's going on and who's using what or who's not using what. You want to look at those pipes, the schematics with the states. Okay, so it's the estate team who'll hold that. And that will tell you how many outlets and when. You'll quickly discover that you've got a lot of redundant outlets. Okay, and these are all prone to leaks. Okay. So you want to know where they are and who they are and where they're coming from. I also strongly recommend a visual inspection of outlets and make sure they actually correspond with the schematics you've got on your system, because sometimes work will be done and you haven't got the updated schematics. So I'll move along. Clinical usage. Now, I have got a document on this, and there's an audit thing. So it's on the Association of Anaesthetists website. There's a really great document that you can use to record all of this work. And in the report I've done for the Greener NHS, there is actually a template for conducting an anaesthetic survey or clinical use of nitrous oxide. I strongly recommend both a survey and quantitative analysis. The survey checks historic use and prospective use. It's really important so you're not getting any aberrations or you're missing prospective use, okay? Qualitative analysis is useful because it gives a realistic impression of how much is being used in a case as well, because sometimes the anaesthetists will, they typically exaggerate how much they're using. So I think it's really useful to actually understand how much is used in a type of case. And that's been really, really useful. Now, as you start to gather all your evidence, I really like decision tree analysis because you often have several manifolds. And I won't spend too much time on this because you can go back and look at it, but what you can do is pull out your threads very, very quickly. And your decisions here, we very, very quickly realized there was nil use, there were leakages, and we knew to terminate this. This is the example, we knew to terminate the manifold. Here we realized we had, low use and, but also, we realized that stock was expiring. And we realized that we needed to review what was going on. So I think this pulls out the analysis very nicely, and it helps people see who aren't necessarily clinical what needs to happen. Now I'm going to get this exemplar is from my site 1. This shows you a typical Dmax cycle. Okay, now if you look at manifold A, this is really, really important. I won't spend too much time on this, but I think I come back and have a look at it because the slides will be available. But you'll see that we didn't change the manifold for over 3 years. We guessed based on some of the data. Unfortunately, it was done at a pandemic period. We knew from that alone, we knew that we weren't using 12,000 litres per annum, okay? Because a bank can hold 36,000 litres, right? And the expiry is around 3 years. What we were suffering from in this one was over provision. So we reduced the bank capacity, okay? And then if you look at the final column, this is the cycle one, we realized we were leaking and we decided to terminate that manifold. Okay, so it becomes quite simple for us. Manifold B, there was a system leak, terminate the leak. Manifold B, again, 0 clinical use was the next outcome, so we terminated the manifold. You know, manifold A, we had very low clinical use, but the stock was expiring. So it became obvious that we needed to just reduce provision of that manifold, but also we had serious stock mismanagement issues. So we went to process mapping. Okay, now what are the challenges? This is all about core stakeholder communication. All of this has been about this whole problem of nitrous oxide mismanagement. It goes back to our level of communication. I cannot stress it enough. The other thing that all this work has exposed is actually really poor training of soft facility staff. That's the porters. Anaesthetists get invested in, pharmacists get invested in, nursing teams get invested in, but soft facilities who are moving around these big luggy cylinders have their training frequently ignored. It's really unacceptable. You'll quickly find that you have issues with private contracts. So where you have maybe NHS or, you know, state-led facilities for the international hosts. So your different contracts will be, you know, confusion over who's doing what will lead to problems in your system. Estate access to theatres is a real issue. It's actually a real problem, and they don't get to check the outlets or penlands, and you could have a leak and it be going on for years. Estate capacity is a real problem, or having skilled personnel is a real problem. These are really skilled individuals, and if you don't have them on site, you're running into problems. I'm going to go over how to build a consultative base. I bang on about this a lot. It honestly, you will quickly fall down if you do not build your a broad base quickly. And you know, and I'll go into all of these and mission drift. So let me move on. The MDT, you want to recruit your stakeholders early, and you want to get executive buy-in. Okay, you want us to share your carbon footprint metrics. So I know Matthew gave a fantastic talk, but honestly, if you share them upfront, tell people what you're doing, and when you sit with these stakeholders, hone your methodology at that point. I know it's tempting to just mimic what I've done, but actually sit down with your QI team and actually work on your own methodology as a site. I really recommend it. And establish a site level aim. I think a great one is zero emissions of all N2O products at your site within 5 years. Within 5 years, I think that's a really good emission, and anything more than that is too tardy as far as I'm concerned. Okay, this is not an exclusive QI theatre project. Nitrous oxide is used ubiquitously across a number of sites. You know, obviously I've talked about piped metrics, but you'll want to be looking at your portable cylinders, especially with Entonox. So you need to centralize this project. It is a major site level project. You will be decommissioning, pipe work. You will need to speak to estate teams. You will be needing to look at contracts. You need to get this fully embedded into your site. Okay, it is not just a little QIP project. All right. Understanding system waste. I cannot recommend process mapping enough. I would become friends with your QI hub. They provide really good soft facilitation skills and can walk you through your site. And also it stops you from making very silly, expensive mistakes. So, you know, I think it's really important that a single clinician isn't driving the decisions, rather that you all sit around and work through your problems together. I think it'll expose capacity challenges really quickly, and also it'll inform your mitigation strategies. Okay, so I think it's really important. I've put some examples. You know, you'll quickly expose lack of training for facility staff, and I think it's really important because any of your strategies may be reliant on them knowing what they're doing. It also, you know, like I said, it can expose deficits in contracts, so servicing of stuff. So again, it's really important if your strategy includes, say, bringing in portable cylinders and you've got theft on your site, well, you've just increased your theft risk. Okay. Assessing lean alternatives and avoiding mission drift. What do I mean by that? Well, I think it's really important that you're creative, okay, that you consider all options and you keep, this is an emerging area of implementation science. I'm learning all the time, and I think it's really important that you don't just be be quite narrow. You have to be quite broad in your thinking, and you have to question odd practice. You have to be quite courageous. I think a single practitioner still using anesthetic nitrous oxide, whereas everybody else is, you've got 100 anaesthetists and only single ones using it. I think you have to challenge that, because servicing that one practitioner is really tough. And I think as pharmacists, we do have a role to do that. So I really, really hope you do it. Consult broadly. Can't stress it enough. These are clever, clever people. They're clever people at the hospital. Talk broadly, bounce ideas. You'll be surprised what you come out with. Okay. Does your lean supply take you to zero emissions? Now, if your team decide they want to move to cylinders at the back of the machine, which our ED department has asked for, I have issues there. That doesn't take you down to zero emissions. They need to come back and suggest how they plan to get to zero emissions, or at least keep reducing their emissions over the next 5 years. So there's still lots to do. Okay. Now I'm going to wrap up quite quickly. These are some resources for yourselves. Now, really do recommend looking at all these resources if you are planning on doing this project. I really strongly recommend pharmacists engage, because where pharmacists have engaged, we get very strong projects, because they bridge that gap between estates and clinicians really, really well. And they're really good at data interpretation as well, and applying that data and making it meaningful. Now, within the UK, I've provided resources of where to secure your BOC data. Again, remember, it's really important to look at the air liquid or BOC data. I'm going to update this slide. I just realized it's a little bit out of date, and I will do that and make sure you have the most up-to-date slide on the website when it comes in. But these are your contacts everywhere else. I'm going to stop there. It's been lovely speaking with all of you. Thank you for your time. Again, thank you to the thank you especially to Pharmacy Declares and Mina. What a great job. And over to you.
Thank you so much, Alifia. What a great talk. So there's a few questions that's come through the chat box for yourself. So one of them is saying, Alifia, can you please describe the extent of C savings if this work is replicated nationally? Are there any barriers to this work being adopted abroad?
Yeah, sorry, sorry, I didn't hear the first question. Do you say what are the savings?
So describe the extent of C savings if this work is replicated nationally.
You mean cost savings?
Yes.
Yes, cost savings, yeah. So firstly, it's not an expensive drug. So within Scotland, we'll be saving, if we can mitigate this agent, we will save roughly around £300,000, just Scotland alone. But the emission footprint, because it's such a high, if you want to add in the the damage caused to the environment, it's roughly about, I think it's roughly about 18, the damage is around £3.5 million. So you've got a cheap drug, but the damage it's causing to the environment per annum is £3.5 million every time you're using it. That's just in Scotland alone, because of the social value attached to this agent. However, the cost savings in terms of infrastructure is a lot more. So if you're servicing a nitrous oxide, reticulated system, you're looking at around £10,000 a year per acute site to service that. So that's a lot. So whereas the agent is relative, but the thing is, if it's not servicing a patient, that's just money down the tubes. It doesn't make any sense. So yes, there are cost savings, but the savings made on the environment are far greater, actually. And the savings made on infrastructure are actually far greater. And the savings made on staff time are far greater. So it's interesting. It's a drug that if you get rid of it, you'll be saving a lot of money.
And Susan was just saying, sounds like a major project. How long did it take, and what was the time work involved? Was it funded?
No, unfortunately, it wasn't funded initially. I did it with the University of Edinburgh for my love of the planet. It's part of my master's dissertation, and part of the, I was involved in the, very involved in the establishing the Green Theatres network within NHS Lothian. And one of the I realized there was a deep resistance or just no movement in nitrous oxide reduction, which just didn't make any sense. Like the behaviors of desflurane it was reducing. It just indicated the anaesthetists had very green practice. They were very self-conscious about the environment. So I just started asking questions about it, and I just realized that actually anaesthetic use was incredibly low. But we do have waste. It's not just waste there. There's waste also with Entonox. Waste runs at around across the Entonox is different. We have shorter runs, which is great, less outlets, which is great. So our waste is around 30% there. But so we do have hospitals that have huge amounts of waste, and we do have redundant manifolds as well. So I'm working with Scottish Government on that as well.
Lovely. I think there's a few more questions that you might want to answer yourself in the chat box. And I believe this is a regional chief pharmacist, Richard Seal, who said that he's looking for replicate your nitrous oxide work across NHS in the English Midlands region. So thank you so much, Alifia.
I'll just say one thing before I forget. One of the things with a lot of hospitals, because there's some English sites here, are planning on decommissioning their manifolds. We are working on a decommissioning protocol because at the moment when gases go back to BOC or air liquide, they are directly vented. What we are trying to do as you're decommissioning your manifolds is preventing an emission event, okay? So we're working on a decommissioning protocol with a Swedish company at the moment who shall remain unnamed, but so the gases are cracked, meaning split into inert nitrogen and oxygen before they're returned to your gas supplier. So bear that in mind. You may need to decommission your manifolds, hang on to the cylinders until those units are provided to you. They'll be portable, so they'll come to each site that are decommissioning. We're doing that in Scotland at the moment. So it'll roll out in Scotland and we'll replicate that across the UK. Okay, I hope that's helpful. Sorry, I'll stop talking.
Thank you so much, Alifia. So now we're going to take a 10-minute break, but it'll be about 7 minutes break. We'll come back at 11:30 UK time, and it'll be 8:30 Melbourne time. So we will see you in about 7 minutes time. We're all going to have a breather for now, and we will see you all back here. I'll stop the recording.